My name is Alan Lumsden. So I'm a vascular surgeon. Strange accent is because I'm Scottish. When I emigrated, I went to Emory, trained at Emory, did my general surgery residency at Emory, did my vascular fellowship at Emory, stayed on the faculty there, then came down here, probably 10 years ago. So we have kind of an unusual setup here in that we have a department of cardiovascular surgery that I head up, and so we're an integrated cardiac surgery, thoracic transplant, and vascular surgery program. So then we started the integrated program. I guess we just finished Cassidy, so we've been doing it now for 5 years. It was kind of an interesting transition. And so that kind of led us to think that we could probably make this transition a little bit easier if we did something like this. So the idea was we started doing it for our own incoming interns. Thought, we might as well do it for everybody. And so hence we created this thing called JumpStart. And so the whole idea is we're going to teach you some of the basic clinical stuff that we're going to expect you to know. And we're really just trying to see whether or not we can accelerate and make it a little bit easier for you to fit in. And so over the next 3 days, we're going to do several things. We're going to teach you things like a vascular H&P, because we don't want to hear all the other stuff. When you get the vascular attendings, they want to hear about the vascular H&P, the relevant part. We don't need to hear everybody smokes. They all smoke. We're going to teach you about vascular anatomy. That's one of the things that drives me crazy. You know, sometimes just knowing the femoral arteries and the groin ain't going to be good enough for you. You're going to need to know a lot more than that. We're going to teach angiographic anatomy because that's the world that you're going to live in. We're going to teach you about vascular emergencies. Now you're thinking ruptured aortic aneurysms. That's the last thing you're going to have to worry about because you're not going to get your hands on that for about another 3 to 4 years. The vascular emergencies that you're going to have to deal with are the nurse calls you and said, I can't get the Foley catheter in. How are you going to be able to do that? What are you going to deal with hyperkalemia, hypoglycemia, patient having chest pain, patient having leg pain? Those are the things that we're going to kind of focus on because a month from now, that's what you're going to be dealing with. So that's really what this is all about. And we're going to combine that with some of the hands-on stuff. So the things in the afternoon that we're going to show you, it's going to be like going back to the anatomy lab because there's a bunch of cadavers back here. There isn't one cadaver each. And so the way we're going to have this set up is you've got a series of exposures to do. We'll show you how to do that. You're going to have to learn to work with a partner. But if you're not right hands-on, you need to start learning to sew. How many people can tie knots? We're in the Reagan thing, trust but verify, you know. And so we're going to watch you tying knots. And if you're not the one who's doing the carotid exposure, for example, use the anterior thigh. Don't use the groin. Don't use where we'll expose the SFA and popliteal. We're not going to have any exposures on the lateral thigh. So you can make incisions and you can practice doing subcuticular closure, vertical mattress, all of these kind of things because we're going to be asking you, about them. You need to start learning the surgical instruments and the basics of what we're going to use, in the operating room. So that's kind of what this is going to be, over the next few days. The other thing is, these are your peers. You're going to be working with these people probably for the next 30 years. I were just laughing that on the wall of my office is a thing that when I went to UCLA review course where they took pictures of all the incoming fellows' hands. I've got that to this day. And those are people who have become my best friends because this is a relatively small community of people that you're going to join. And it's a great group of people. You're going to have a blast, but it's hard. And we just finished running a course last week that we called Finishing School. So the way we've got these educational programs set up is that in August we do boot camp, and we do boot camp for incoming fellows. Okay, they're kind of at a different level, and we mix them with cardiology fellows, cardiac surgery fellows, vascular fellows. We're just teaching the basics of cardiovascular disease. Now, if that's something you're interested in, you can't come because that's all designated for those folks. But online, we'll show you all our social media websites. All those lectures are up there. And so the whole idea of that is teach broadly, teach early, and teach the basics. Then we just finished this weekend what we call finishing school. So we have fellows who are finishing. They're done in June. And that's a much more complex set of things that we're teaching. Branched aortic endografts, for example, crossing chronic venous occlusions. What we're trying to do with you, we're trying to gauge this for what you need at this particular point, in your education. And now you need help in that transition. How do you put in a central line? So I call you a month from now, or you call me a month from now on the weekend and say, hey, this patient needs dialysis access. And I go, okay, we'll just stick a dialysis catheter in for me then. Are you going to be able to do it? Now, I'm not advocating that you go off and do that. You can kill people with dialysis access things. You really should have somebody there the first few times you're doing it. But you're about to be on the front line. This is a fundamental difference from being a medical student, where we expect to hold your hand every step of the way. Now you're going to go into doing something a little more sophisticated. So what we showed, because really it was a graduation ceremony for the people who were at finishing school, so we showed that commencement address from Admiral McCraven, the Navy SEAL Admiral, talking at the UT commencement. Let me show you some of this. And you're almost going to be kind of the Navy SEALs of surgery. That's what we think. I mean, vascular surgeons are generally perceived as being technically excellent. You get to operate everywhere. We're kind of the last of the general surgeons. We have a broader portfolio of places we're going to operate on. The general surgeon, you're going to go from the base of the skull. We did this huge carotid body tumor last week, all the way down to the tip of the toes. And you're going to be in the chest. And so there's not many specialties that get to do that. But you got to know the anatomy, and you got to know some of the basics. And those are the kind of things that we're going to show you really over the next few days. And we're going to give you homework. So now we're going to test to see if you've actually done any of the homework that we sent you. Did you do it? Did you see the videos? I had no answer to that. All right. Can you scrub? Do we know how to scrub? We don't want the nurses yelling at you first day you come into the OR if you don't know how to put on a gown and gloves. So when you gown and glove back there, basically take it seriously and get through it. We're going to show you. I want to see if you guys know what these things are. Okay. What's that? Don't say pickups. Well, I know they're pickups. What kind of pickups are they? AdSense. Why the AdSense? What do you use them for? Skin. Little teeth down here. Typically use them basically for closing skin. You evert the skin to put on the subcuticular stitch. What's that? Could be a bunch of things actually, depending on the scale. Can I hear you? Loud and proud is what we say. You may screw it up, but at least be bold in shouting it out. Yeah, what do you think it is? A hemostat. Okay. So they come in different sizes. Mosquitoes, like a smaller version of the hemostat, and Kelly clamps basically are the bigger version. What'd you use that thing for? Hemostasis. Yeah, but how'd you just wave it over the wound and it all dries up automatically? How'd you use it? Hey, clamp vessels. Well, how'd you get the vessel? Grab it, pick it up, clamp it. Sometimes you just stick it in the tissue and clamp it. All righty. No points for saying these are scalpel blades. What do you use this one for? 10 blade, skin incision. What do you use that for? Hey, how'd it go? We're in the process of epic transition over the past 24 hours, and Thomas here is our epic leader. Was it bad? He's shaking his head.
No one died.
No one died? You mean at resident level or patient level? Yeah, all right. All right, so 15 blade. So what's going to happen is our faculty we do have a service to run at the same time as we do all this kind of stuff. So the faculty were kind of drifting in and out. Thomas is our research resident, so they're going to be helping with you back here. What's that? 15 blade. What do you use that for? Can't hear you. If you don't shout it out, I'm going to start picking on people. Yeah, a little bit more delicate. And you can use this for a variety of different things. You can even use this for opening arteries, but it's much smaller than this. What about that bad boy? Nobody ever uses those here. We used to use them at Emory all the time. Hook knife, we use it for entering blood vessels is one thing you can actually use. You can use an 11 blade, which is just straight with a point on it. This has got a curve, and so the way you take it is you enter the artery, lift up, make a little incision, and then you're going to open the artery. So once you make an incision in the artery and you got a little bit of blood, how do you open the artery? What kind of scissors do you need? Very good. Very good. Forget that. Okay. What are these? Suction. And so different kinds of suckers. I mean, this will suck at the point. You put your finger on the side, sucks a little bit more, sucks the tissue up, you release it, and it releases the tissue, as opposed to sump suckers, which have got multiple holes along it. So if you've got a belly full of blood and you don't want to suck the bowel down on it, you need what's called a sump sucker to be able to put in there. All right. Electric artery, bovies. Okay, what's the difference? Yeah, well, that's pretty good. Pretty good. I'm kind of surprised. All right. And a different kind of scissors. These are kind of use these for cutting dressings and things like that, or cutting a graft, for example. Basically, if we've got it, what's that? Towel clip. We clip the resident. If they're misbehaving, we basically, believe me, I've seen that put through people's fingers, and it's not a very pleasant experience. Stapler, you've kind of, oh God. Okay, so at least you looked at the videos. That's what this was designed to do. Okay. Any questions about the videos? Did you practice tying knots? Have you had a chance to do that yet? We're going to start talking about my favorite topic, anatomy. I trained in the British system, so I actually got taught some anatomy. One of my partners at Emory, who was an Egyptian, he trained through the British system, says, anatomy is an elective subject at Emory University. I'm not sure what has happened to anatomy teachers. So we're going to go through all of these things, and we're going to take you down the aorta from top to bottom. Okay, if you can't describe the different parts of the aorta, you can't describe it to me on the phone. So just remember that you have to be able to communicate. When you call us in the middle of the night, first thing you got to do is convince us you actually know what you're talking about, because that's going to keep me in bed. And that's basically one of the more important things you got to do is you got to keep the attending in bed safely. Oh, what is a bad situation, whereas we go, yeah, okay, that's fine. That food will be fine till tomorrow, and we walk in the next day and go, oh my gosh, that is not a good situation. So we need to be convinced that you know where the pulse exam is. We'll kind of go through that, and we need to know that you can judge severity. One of the things you really need to be able to do is sick, not sick. Everybody's sick. I'm talking about sick. Patient's going to die or something bad's going to happen. And one of the biggest problems that you're going to have is you'll be evaluating ischemic legs. Critical limb ischemia that needs something done about it now versus sitting on it till the morning. It's always better to do things electively if you can, but one of the most common reasons you get sued in this business is because you miss an ischemic leg. And so you sit on it for 6 hours. And this is how the deposition goes. Is more ischemia worse than less ischemia? Doctor?
More ischemia is worse.
More ischemia is worse. So are you more likely to salvage that limb if you operate later or earlier? Okay, so you operated 8 hours versus 2 hours. Would you have been more or less likely to salvage the limb at that point?
2 hours
more likely to salvage them. Okay, so I'm looking at your hospital record here, doctor, and it says at 2 o'clock in the morning you recognized the patient in the ischemic limb, but you didn't actually do the surgery until first thing the next morning. Can you explain that to me? What was the benefit to Mrs. Smith of you not operating for 7 hours? And that's what will happen to you. You get led. You got to be sure that this is okay, because they will lead you down the garden path and they will bury you with your words about what is going on there. Okay? So again, the majority don't need to be operated on emergently, but you got to err on the side of if there's any doubt about it. And the problem for you is that you're going to be in the hospital, so you're going to get to see these patients. And you're going to be communicating with me on the phone. And I got to be able to know that you know. So the first thing you're going to have to do is establish trust with your upper level residents and attendings. Thomas, jump in. You want to say anything about it? It means the middle of the night, it's the phone. You really don't want to bother the attending, but you're not quite sure. I mean, these guys can give you real world experience. I'm slightly removed from being an intern, but you want to make any comments?
If you're not sure, you may get yelled at, but that's a lot better than something bad happening, because it does happen. And I've been here now 4 years. Probably 10, 12 times between general surgery and vascular surgery where there's something bad has happened simply because someone didn't want to wake someone up, or they didn't want to bother someone, even if they're in the hospital. And it's always worth it. It's better to get someone
That's real world experience. So for example, when I was at PGY2 in the emergency room at Grady, the trauma chief would come down and say, I want you to be strong. Don't bother me. That is absolutely ridiculous message to give to a junior level resident, because all that is hurt a patient. You know, who cares about waking the guy up in the middle of the night inappropriately? You're much better doing that, suffering the heat that you may get associated with it. But the idea that we're just going to rock patients home so we're not going to bother somebody is it's kind of the surgical folklore type thing that is a big mistake and can really hurt people. Okay, so we're going to start talking about anatomy. I'm not really going to spend any time in embryology. I mean, everybody knows that there's 6 pairs of arteries. You kind of need to know that some of the different components that the aorta arises from, this is not what we're going to spend time on. And as it developed, the reason it's important is because of this. There are certain situations where you get persistent congenital rings around the aorta. For example, the most common one that you will come across and you will see is an aberrant left subclavian artery. An aberrant right subclavian artery. You can get them both actually, and they can trap the esophagus. And so you get these vascular rings that typically present basically with compression of the esophagus. So sometimes every now and again you're going to see this. An aberrant right subclavian artery typically courses behind the esophagus and usually arises from the descending thoracic aorta. And the other reason that's important is it becomes aneurysmal over time. It gives you a thing called a Kommerell's diverticulum. So they present with dysphagia. You get this funky looking saccular aneurysm come off the descending thoracic aorta, and it's not that easy to deal with. We're not going to spend time on this. All right. You're a red cell. Travis, you're a red cell coming out of the aortic valve.
Yep.
Where can you go?
Ascending aorta to the head, to the arm.
Okay, do you know what the ascending aorta is defined as? What is the ascending aorta?
Valvular junction to the LA nominate.
Yeah, very good. All right. Now we get to the distal end of the ascending aorta. Where can I go?
To the aortic arch.
Yeah, we're going in the aortic arch, and what are the branches? Okay, very good. And so the distal end of the arch is defined. Basically, you draw a line across here, and that's going to be the ascending. That's going to be the arch of the aorta. Now, what happens is there are a variety of variants. What's that thing? Pretty good. How often does that happen? Tells you up there, 5%. Why is that important? Who cares?
Because if you put a graft there and cover it.
Yeah, that's when it becomes important. Is that you will see this. You will see this not infrequently. Usually pick it up in a CAT scan. And this is an area you're going to be landing stent grafts in if you're going to be treating dissections. And if you're going to be a variety of different things. Sometimes you're going to cover the whole aortic arch. So let's say you see this and you're going to cover it with a stent graft. What do you want to know?
But the other side is.
Very good. To the right. So how are you going to do that? So if you're going to be covering the left subclavian, same idea basically, or you're going to be covering that vertebral artery, you want to know what the other vertebral looks like. How?
Find the other subclavian, dissect a little further.
Oh no, you're not going to be operating this. You're not going to be opening that. This has all got to be done pre-operatively or intraoperatively. We didn't look at the CAT scan right. We didn't see this. We shoot in the aortogram, and all of a sudden we see this thing coming up here, and it's like, oh my Lord, I got to cover that. And I just covered it. You probably can, but if you get it wrong, you get it wrong big. Okay? So you need to know what's going on in that vertebral on the right side. And the way you're going to see that, you should know about it pre-operatively, first of all. You can go back, but if you haven't noticed it, go back and pull the CAT scan. It's probably there. Okay? Ultrasound's the other way you can look at it pre-operatively. Ultrasound shows you. So if you get a carotid ultrasound, you should be getting pictures of both carotids and both vertebrals. All they're really going to tell you about the vertebrals are antegrade flown on both sides. But let's say we ain't done it. Now we're in the OR. And you go, oh my Lord. Never realized that thing was coming off the aortic arch. Now what? Catheter up here, shoot some dye, and look at it. What's PICA syndrome, do you know? Ever heard of PICA? You've heard of it, good. Okay, maybe you could embellish and help the rest of the class understand what it is. It's going to be a long couple of days. No, it's called posterior inferior cerebellar artery syndrome. So the first branch coming off the vertebral is PICA, posterior inferior cerebellar, okay? And the vertebral dead ends into it. Does not communicate with the basilar. Happens in about 5% of people. So if that doesn't communicate with, or let's say the other side doesn't communicate with the basilar, and we cover that, then it's a problem, okay? Because that's the thing that's supplying the basilar system. So one of the things you're really looking at is to see, you just really want to know, are they both patent and are they both communicate with the basilar artery? Those are the kind of things. And by and large, you can cover these pretty empirically if both are open and flowing up there. Okay, what's this? Is that cow anatomy? Apparently it's not. You know, the great story is it's not, okay? So, everybody understand what this is? The reason that's going to be important to you is because this makes it much more difficult to catheterize the left carotid artery, okay? You got to come up, over, turn the catheter around, and go backwards in order to be able to get in there, okay? And so it makes it a little more challenging. It helps you with the stent graft placement because usually the origins of these things are huge and wide, and so we can encroach on that basically just a little bit. And it's not always like this. Sometimes that carotid is coming higher up. So it can be anywhere, you know, along that innominate axis. And then this is what I'm talking about is the aberrant right subclavian artery, which is the most common congenital anomaly that you're going to find there. So it's running posteriorly, it runs behind the esophagus, and the esophagus gets compressed between that and this. And typically that origin will degenerate over time and form what's called Kommerell's diverticulum. Any questions about this? Alrighty, okay, so we're walking down this thing now. Now, aortic arch, next row. What happens as you get older to your aortic arch, do you know? Get bigger, get smaller, get wider. It widens, okay? So typically what happens is that in a young patient, and this is something you will look at a lot, okay? And so how narrow that arch is determines the degree of difficulty in taking big devices up and over that arch. And so what happens is that if it's tight like this, you tend to drive the devices up, and it may not make that transition. And so you're always watching here. So when the device comes up, you want to see it turn on those wires and go over there. You don't want to be jamming these things through the top of the aorta. And so typically, the older you get, the wider space the aortic arch is. But the other problem, what happens is that as the aortic arch widens, these supraortic chunks slide down more onto the ascending aorta, and we classify that into type 1, type 2, and type 3 arches. And in a type 3 arch, essentially these are now coming off the ascending aorta because of the way the aortic arch now extends up into the apex of the left chest. And the reason that adds to complexity, technical complexity, fairly dramatically, because if you're trying to catheter and do a carotid stent, for example, you got to come up and down and back. And so when you push on the device and a wire is coming like this, it tends to push the device superiorly rather than track it up and over the wire. And you kind of have to adjust the wire stiffness in order to be able to compensate for that. Okay, so unmarked artery, what's that? All right, I'll go one at a time. It's better that way. What's that artery?
Internal thoracic.
Internal thoracic. Often referred to as the mammary artery. Why may that be important to you? So a patient comes to see you. They've got a left subclavian stenosis, right there. They have an intermittent chest pain.
You have like a Lima graft?
Yep.
You don't want to cover it. And
So what?
If they have a cavity, you don't want to cover it.
Yep. So what's that called? Anybody know? Coronary subclavian steal syndrome. Okay. Patient uses their arm. You will have reverse flow coming down the vertebral artery because that's how the arm is filling. When you use the arm, it steals the blood away. Sometimes they get subclavian steal syndrome, which is they just get dizziness because of posterior circulation symptoms. But in a patient where this has been taken down onto their LAD, they sometimes present with chest pain. And so that makes a big difference in terms of how you're going to actually deal with this. So And the other thing is they may not have a sternotomy. One of the things you got to be really careful with is a lot of these are being done through a left thoracotomy, and on a beating heart, patient may not have a sternotomy to tell you what's going on. But if you turn on the fluoro and you haven't figured this out in advance, you see a bunch of staples. Parasternal means that lemur has been taken down. It's probably on there. You cannot lose the internal mammary artery. I mean, that's sacrosanct, actually. Okay, so what are you going to do? Patient's got coronary subclavian steal syndrome. They get EKG changes. They got a left subclavian stenosis. Yeah, so there's a couple of ways of doing this. I mean, the options are you can stent this, which is how the majority of them. If it's narrowed but not occluded, you can usually open it pretty easily. Occluded subclavian. The problem is you occlude the subclavian here, clots right up to there. Okay, so you have a long segment occlusion that you're going to try and cross. So if it's stenotic but open, you're going to be able to treat it. If it's completely occluded, then typically what you do is do a carotid subclavian bypass. And at that point in time, you never really have to shut down the blood supply to that lemur at any point. It's baseline, and you will make it better. All right, so based upon patient's got an occluded subclavian. The boys are out there going, we can get this thing open. What are you worried about? Based upon purely with this anatomy, what can happen? Right, where? Again, this is why we keep beating on the anatomy. Without understanding these pathways, you can't understand the complications that can happen. Okay, just basics. I fire a stent in here, a piece comes off. Where can it go?
Without anatomy, to the heart.
It can go to the heart, okay? That doesn't happen very often, actually. It can go to your vertebral artery. Okay, so stroke is one of the complications. Anytime you're messing with the subclavian artery, you got to be consenting this patient, that there's a risk of stroke that's associated with it. Or it can go down the arm. I mean, those are the three places that can going down the arm is the most benign of all these places that can actually go. So knowing that means you can go down there and go up that. You don't have to worry about these branches going up into the neck, and it can go down into the arm. Okay, and so one of the things that's very different on these two sides, okay, subclavian stenosis on the left happens here. Subclavian stenosis on the right side happens here. Now you can get a nominate stenosis, but you also get subclavian stenosis. Okay, so anatomically, I'm going to put a stent on the right subclavian artery. What are you going to worry about? Where can it go? It's just anatomy. There's no trick questions here. So the problem with the stent is it's almost impossible to land the stent right here, so you're going to have to extend it down here. So it's going to encroach on the right side on the carotid artery. It's not going to encroach on the left side on the carotid artery because they're usually separate unless there's a bovine origin for that. So again, we're more worried we can get on the right side, we can get embolization in the anterior circulation up the carotid, and we can get embolization into this. Every now and again, the right internal mammary artery is used to revascularize the heart. They generally don't like to take both of them because they're higher incidence of sternal wound infection when they do something like this. But it's just a matter of knowing the anatomy to understand what these various different embolic pathways actually happen to be. Any questions about this? Okay, so again, this is just the vertebral artery we've talked about. This is so the word that is used to describe an aberrant right subclavian compressing the esophagus is dysphagia lusorum. That's one of these trivial pursuits things that somebody will ask. A little bit easier to treat an artificial stenosis on this side, but that doesn't happen. It doesn't happen when you get that. Instead, that entire area degenerates. You see this big saccular outpouching, and that patient needs to be operated on. They always kind of get better. Always get worse, I should say. Okay, so this is really talking about what I mentioned about the different patterns on the right side of the bovine pattern. Sometimes it's way up here, sometimes it's down here. Doesn't really matter. You got a chance to dissect all this kind of stuff out and look at it this afternoon. Now, one of the issues you will deal with is, what is a normal diameter? And the reason that these are important to us is because we're making intervention decisions based upon what the diameter of the aorta actually is. Now, typically, it's usually said that aneurysms twice the baseline diameter, normal diameter, equal an aneurysm. And those are the indications really for going ahead and intervening on them. So this just gives you an idea. we've always said 5 centimeters you operate an abdominal aortic aneurysm. Well, 5 centimeters a small woman is a relatively large aneurysm, so you kind of need to know really what these are. And this is just an example. We see in a woman, it can be as small as 1.19 centimeters. So 4 centimeter aneurysm may warrant intervention. So we tend to individualize in these patients. We're not going to go through this. Okay, so this is what I was talking about, was the various different types of arch. Type 1 arch essentially come off at the apex. That's easy. Catheters come up from the groin. You can't keep them out of that thing. Typically, when you pass a wire from the groin, it usually goes up, in this situation, the left subclavian artery. You always want to know where the end of that wire is, okay? I will guarantee you that in the course of your career, you will see 2 or 3 patients who will be badly hurt by not knowing where the end of that wire is. And so the places that get you in trouble are in the renals. The wire will go up the groin. Renal arteries vary between, in the books, they all look like they come off at right angles. More typically, they come off like that, and that makes them an SOB to try and actually do anything too. And sometimes they come off like that. Animals, for example, pigs, they come off like that. Wire comes up the aorta, straight into it, and you put one of these glide wires out there, it'll go straight through the cortex of the kidney. And you may not even know that you've been out there. And then post-operatively, this happened to a board member. Mercifully, it was done in interventional radiology and not by us here, by very experienced people who they did, because they were a board member, bilateral renal artery intervention at the same time. You almost never do that. So you never want to be a VIP. You just want to be treated like everybody else gets treated. Not, hey, it's going to be a pain in the butt for this guy to come back. Let's just go ahead and treat them both at the same time. Post-operatively, got belly pain, had bilateral subcapsular hematomas. And so they bleed underneath the capsule of the kidney, they compress the kidneys, and this guy had full-blown renal failure. Now, fortunately, it got better, but it's an example of, even in experienced hands, these wires will go up there. We tend to think of wires as benign. Wires are anything but benign. And you don't want them running up the vertebral artery into your head and not really knowing exactly where they are. So keep an eye on where the end of the wire is. And so again, one of the challenges when you're doing this is coming up and over here. Let's say you're doing a right carotid. Now you got to basically bring that up, and when you push the device, it pushes down into the heart, pulls the wire back. There are different ways of handling this, but those are things that add to the level of a complexity of a procedure. When you're choosing carotid stent versus carotid endarterectomy, if you had a type 3 arch and a patient with a lot of atherosclerosis in it, you probably don't want to put a stent in there, because there's so much motion taking place as you bring these devices that you tend to embolize. Okay, I think we got most of that covered. I mean, this is the one I think that we've not covered, is every now and again you get a single trunk. I've personally actually never seen that in a patient. Okay, now we're going to start getting really complex. Used to be that all we really needed to know was up to here. Not anymore. If you're going to be doing carotid stents, you got to at least know the basics of what's going on inside the head. Okay, where do we get to? You're up next. Talk me through your red cell coming down here, and I got you in the right carotid. Where can you go? Okay, so let's say you're looking at my neck. Where's the internal versus the external? Is the internal normally this one or this one? Is it usually, internal is usually postural lateral, okay? So you come up the medial side of the carotid, you dissect out, and you come across the external carotid artery. And the internal carotid artery is usually in line postural lateral to it. As you approach it, from the incision that you're going to make. Every now and again, it'll be completely reversed, okay? All bets are off at that point in time. Or typically what happens, if this is the external, you're coming in my side, it's often like that. And so what happens is that you're coming up and dissecting the carotid, all of a sudden there's all these arteries that shouldn't be there. And that's the first clue that this is rotated. Now again, we should have picked this stuff up pre-operatively, but if you're just going to operate on basis of an ultrasound, you don't have any kind of anatomic relations that you can look at. So if you suddenly find there's branches that you're coming across arterial bleeding, it's usually because it's rotated. And the first thing you got to do is dissect it out and rotate it back into position. Because the internal carotid artery, what's the first branch of the internal carotid artery? Oh, getting hard. We're up in, well, I'm not even going to tell you that. That's the clue. Anybody know what it is? No, ophthalmic is the first one up inside the head. Comes off the cavernous sinus that's up there. So what are the branches in the internal carotid artery in the neck? None. Usually. Every now and again, you know, somebody throws one in there just to trick you. But again, if you see branches coming off it, it's probably the external carotid artery. How do you tell the difference? So we got branches on one. What else? Oh, that's very interesting. Yeah, but that's kind of a pain. Hopefully we can figure it out without. You can. What's the difference? Because you'll end up talking about this the next couple of days.
The internal carotid is going to have a lot more prolonged runoff versus the external carotid.
So if you look at the waveforms, and we go on the internal, you'll have a systolic peak. It will not come to baseline, and it'll drop, and it'll go up like that. So it has continued. Think of it, your brain needs more blood supply than your face. So somebody basically has figured out that you have prolonged flow and diastole, and that occurs because there's a low resistance pathway. If you look at the internal carotid, or the external carotid, you get these sharp peaks like this. And that is one way that you can tell it. Now, while we're doing that, sometimes the problem you're going to be dealing with is that you're not operating them because they're normal. You're operating them because they're abnormal. It's easy when they're normal, but you're operating them because there's a stenosis here. And so the other thing you can do, Amy, no? So you're on the external, or you're on an artery. You have no idea what it is. Maybe may or may not be open when you're doing this. Where's your superficial temporal artery? Amy, how do you find it? So again, you're communicating with me over the phone. I can't see this. You got to explain anatomically where you're going to find the superficial temporal artery. Lateral. Yeah, I got big ears, man. It could be anywhere from here to here. Anyway, how do you find it? Oh, okay, yeah, well, a little bit, but that was zygomatic. The arch goes from here to here. So it's tragus of your ears, this part, 1 centimeter anterior to is where the superficial temporal artery should be. And you may need that if you're going to do a temporal artery biopsy. You do that for rule out giant cell arteritis. I hate those operations. I've had more complications from doing this than from doing aortic surgery because they are an SOB to find. But if you've got an ultrasound probe on the external carotid artery, you can do a thing called the temporal tap. Yep. You do this. You bang in the front of your ear, and you'll see the transmitted back to the waveforms that you're looking at. Well, if it's the internal, you won't actually see that. Okay? That's extra. That information will charge you extra for that. All right, so you're looking at it in the neck. I got it partly exposed. What are the other hallmarks of the internal carotid artery versus the external carotid artery? External carotid artery is usually medial, anterior medial. It's usually got branches. Internal's got, you know it. You know the answer. You're just not thinking, you're just not articulating it. Is it bigger? Is it smaller? Does it have a bulge on it? There's a bulb. It's like the carotid bulb is on the internal. So typically it's like this, okay? And you can see that. And that's important to you. So these are the different ways that you can identify what you're operating on. Okay? Let's keep going. Now we're on the external. Now it's getting a whole lot harder. Maybe what's the first branch that you're going to come across? Severe thyroid. So you see the severe thyroid all the time. Sometimes it comes out of the common carotid artery. More usually it comes out of the external carotid artery. Is it important? Nah, you can usually just divide this thing with impunity. Okay, so that's the level of the bifurcation varies tremendously and will vary the complexity of your life in dealing with this. Typically, it's about 4 or 5 centimeters below the angle of the mandible. What you'll hear people looking at is the angle of the mandible in relation to the carotid bifurcation. If it divides at the level of the angle of the mandible, then the exposure is very difficult distally. So typically it's going to divide 3 or 4 centimeters below it. The plaque, which is the most common reason you're going to be operating these patients, typically basically will extend up for 2 to 3 centimeters. And as you dissect down the internal carotid artery, I always tell the residents, you're looking for blue. Okay, the hue and the wall of the artery will change from yellow, plaque, to have this blue hue in it. And at that point in time, you're looking at normal artery, and it's clampable. You don't want to be clamping through the plaque. You got to get up above the plaque in order to be able to clamp it and successfully do an endarterectomy at that level. Okay? So that's kind of what you're looking for. And there are a whole bunch of other structures not shown here that we're going to get around to looking at. Okay, so now we're starting to look at angiogram. We're going to start blending. The reason you got to know this, you're never going to figure this out if you don't know this basically in the first place. And so the reason this is up here is if I lie on a table and I shoot an X-ray beam straight through me, this is what you will see, okay? You have no idea where the origins of these vessels are. Everything is superimposed. So it's the difference between the 3 supraortic trunks like that and like this. You can't tell them. So you know what LAO is? Left anterior oblique. And the way, because the aortic arch is running almost directly anteroposteriorly, is that in order to open it up, and you hear this phrase used again and again, to open up the arch, you got to swing the image intensifier into left anterior oblique. Typically, it's 50 to 60 degrees LAO. Everybody's different, okay? So the way that you kind of do this is the first thing you do is usually have a wire that's going to come up here. That wire will look tight. You swing the image intensifier and you will see the arch. You'll see the wire go like that. As you go beyond the point, it will start closing down again. Then you back the image intensifier down into, so you've got this maximally opened up. So you don't need to know what it is. You can figure this out, as you're going basically in the hybrid room or the interventional suite. How many of you are going to places that have hybrid rooms? Hands up, loud and proud. Almost everybody. Who's going places that are only using C-arms at the moment? All right. Beat on them. All right. That's amazing. There's that number, actually. That's good. Okay. So these are things that we're going to basically we've talked a little bit about. Okay. What's that? Got a big black dot right there. Is that an aneurysm? So it's a bovine arch. The arch is nicely opened up. And there's that funky looking black area on here. So let's say you see this in the hybrid room. Next step. I don't know what it is. I really don't know what it is. Change the angle, okay? This is normal, okay? This is a double density. What you're seeing is you're looking straight down the takeoff of the right subclavian artery. So it's projecting towards you and then coming backwards. This will be normal. But it's very easy to see composite shadows and to mistake, what's going on. So what's this? Right vert. What's that? Right carotid. What's that? All right, what's that? Why is the right vert bigger than the left vert? Usually one's dominant. Which one's usually dominant? Usually the right side. But it's not. You can't really depend on. What are these things? Can't see them very well. Sternal wires. Okay, sternal wires can help you because you can use them to if you're going to, for example, be intervening in the aortic arch. The sternal wires you can see. You don't need any dye. So if you shoot dye in the first time, you get a pretty idea. Let's say that top sternal wire is going to be my anatomical landmark for when I'm going to deploy a stent, for example. And so you can use these things, bony landmarks. We're always checking off against bony landmarks to guide deployment because this is not usually there when you're actually deploying these patients. Okay. All right. Now it's going to start getting a little more complicated. So angle of the mandible, bifurcation. And this is kind of the way it typically looks. All right. Let's walk down. This is how anatomy's been taught to you. It ain't going to be like this when you basically make an incision in somebody's neck. All righty. Manny, we're going to do a carotid endarterectomy. How are we going to do it? Patient's lying on the table. First thing, it starts with the position of the patient. Okay. So you want to extend their neck. If I'm going to do the right side, I'm going to rotate their face to the left side. You've got to support their head. We always want to extend it more. Anesthesia is always trying to extend it less because they're worried about pithing the patient, which is probably good that they're there to defend. And patients with slim necks, not a big deal. And patients with a short, fat neck, it's a big deal positioning these patients. So you want to be involved in positioning the patient to start with. What are we going to make the decision?
So make it just medial to the border of the sternocleidomastoid.
Okay, so Typically it said you make an incision along the anterior border of sternocleidomastoid. What we do is take the ultrasound. First thing you do is scan them intraoperatively, and this is why it's important that you learn how to use the ultrasound, and you'll learn that. We use ultrasound. We never stick an artery or vein without using ultrasound. Doesn't make any sense. There are ultrasound machines all over the place here. You stick my neck, give me a pneumothorax, and my jugular vein is occluded in that sign. Doesn't make any sense to me. I mean, this is like the stethoscope of the future. You need to learn how to use ultrasound because we interact with ultrasound all the time. This is an example. First thing we do is scan the neck, find where the bifurcation is, target that incision. And there's two different incisions. You can either go along the anterior border of sternocleidomastoid, or you can oblique it and put it in a skin crease. Depends upon how extensive the plaque is. If it's a little localized thing, then just make a skin crease incision, probably works better. Okay, so this is the way you're going to think about surgery. You're going to, I think anatomically. I'm looking at that patient's neck, and I want to know where the bifurcation is. I've marked it. I'm going to give you your incision. Skin. Next. Made an incision in the skin. Stop the bleeding. Always stop the bleeding from the skin edges in the neck. Bleeds like hell. So score the skin, take the bovie, do almost the rest of the exposure with electric artery. Well, what am I going to go through? Skin. Give me 2 more layers, and then I'm going to basically, I'll move it on. Subcutaneous tissue. Next. What's platysma? Okay, that muscle. Yep, so you divide the platysma. Next. What am I looking for? Skin, subcutaneous tissue, platysma. Now, this is what's going through my mind every time I'm basically doing this. There'll still be a little more fat. In that fat, I am looking for what? All the answers are up here. Pardon? Yeah, I know we talk about the carotid sheath. It's not exactly a defined anatomical structure for you to look at. So next thing we're going to come across. See that big blue thing? It looks like somebody ligated. Don't ligate it. Huh? So again, the difference between showing you this and what you're going to see is you're going to be seeing this. Okay? So skin, subcutaneous tissue, platysma. There'll be fat, and that fat is the anterior border of the jugular vein. You're coming down right down here. If you're back here, you got the wrong incision, or you're dissecting in the wrong place. Sometimes you walk in the residence, it's got a beautiful dissection of the whole jugular vein. You go, what the hell is that? I've never seen the jugular vein dissected out doing a carotid endarterectomy, because all you need to dissect is what you need to do to get there. The more dissection you do, the higher the complication rate you're going to get. So you're going to be coming down this area. There's a branch that comes off the jugular vein. What's it called? Common facial vein. I don't know where it is here. They took the whole thing out. This is not how you do a carotid endarterectomy. This is an anatomical dissection. So the common facial vein bridges anteriorly. So you're dissecting now the anterior border of the jugular vein. You'll come across the common facial vein. We always say it usually marks the bifurcation. I'm not entirely sure. Venous anatomy is so variable. Okay, so now you're going to divide the common facial vein. The common facial vein is as big as my finger. How are you going to divide it? Yeah, typically suture ligate it, okay? When they get big like that, clamp, divide, pick it up, suture ligate it. We'll show you how to suture ligate things basically in the next couple of days, because you don't want it coming off. I mean, it's just a mess if it comes off. Okay, and at that point in time, you're going to displace the jugular vein posteriorly. So retractor goes in, retractor goes on the jugular vein, and you pull the jugular vein back out of the way. I don't ever want to see the jugular vein again. The only other time it comes into play is if you're coming up here really high, that jugular vein, and it's often compressed below, will come back across the top of the internal carotid artery. You just got to be careful you don't cut it. I've actually ligated the internal jugular vein, mistaking it for another venous structure. Because when you put these retractors, it collapses down. These veins can get huge and then get small. And sometimes when you've got them compressed down below and compressed up above, it looks like nothing. So you just got to be careful that you don't do that. So the next thing, we're going to come down. We displace the jugular vein, finger in the hole, you feel the pulse, okay? And you're going to operate on that pulse. So you're going to have your finger coming down here. I can feel that pulse. Snip, 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 right down the carotid. You try to expose the front of the carotid as fast as you can. Because what else is back here? What else can I nail back here? I've avoided the jugular vein. I'm on the carotid. The vagus nerve, okay? Now, so typically the vagus lies posterolateral between the jugular vein and the carotid. Often it's around the back of the carotid artery. You don't cut it very often. I think it gets clamped a lot more often than you cut it. All right, so I ligated the jugular vein. Now what? Pardon?
You did that on accident?
Yeah.
I don't know. I've never seen that happen.
Thank you, making me feel good. It probably doesn't matter. We'd really like to know. I'd take an ultrasound and look at the jugular vein the other side, make sure it's patent. If it's not patent, you probably want to try and put it back together again. If it's patent, you probably just leave it. Okay. All right. Now we've cut the vagus in half.
Oh, crap.
Yeah.
We'll check their vitals. Make sure they're not
That doesn't happen. Don't worry about the vitals. You won't even notice it.
the other side.
Yeah, well, there's no way of checking the other side. That's the slight problem. There's not much you can do about it when it's happened, and that doesn't happen because we're always looking for it. I mean, it's first. So you look at the carotid, you're always looking for the vagus, and typically we dissect the carotid artery, leaving the vagus back inside. It's more likely to be clamped. But okay, let's say, what are you going to tell the patient? You're doing the pre-op, and you're getting the consent. What are you going to tell the patient? Pardon? Yeah. No, what are you going to tell them about nerve injury? Now we're getting up into these nerves. A whole bunch of nerves up there that we will injure.
Sometimes they can heal.
Pardon?
Sometimes they can heal themselves if they've done.
Yeah, that may take months. You still got to explain why there's various different things going on with them post-operatively. Next, all right? No, I'm going to give you a nerve. You tell me the manifestation. Cut the vagus. Clamp the vagus.
Braid down, horses.
No, it won't braid you down. You won't even know. Well, it doesn't happen. I mean, forget all this cardiovascular stuff. It doesn't happen. Yeah, they don't really have swollen issues from this. They have hoarseness, okay? And they'll talk like this. It's not that they can't talk, but the quality of their voice will change. It's not the end of the world, except that they sometimes aspirate. But it's a big damn deal if they're professional singers. I mean, I've done a carotid on an opera singer. And it's one of those things that no big deal from your standpoint. They tell you they're a professional singer post-operatively. Well, then it's a big deal because they ain't going to be a professional singer anymore once you injure this. How do you confirm it? Scope. You look in their larynx and get them to do what? Cough, and they get this paradoxical motion basically of their cord. You can inject a cord. Most of these things get better because they're usually not cut; they're just kind of stretched or traumatized. You can inject the cord so it kind of opposes more to the midline. It's so-called in the cadaveric position. It's halfway between abduction and adduction, and they can't close appropriately. And so you can actually fix the paralyzed cord so that the other one can actually oppose it. What other nerves? There's lots of nerves in there we can wreak havoc with. What is probably not even showing there? All right, what's this one? Pardon? Hypoglossal nerve. So what's that thing coming down here? That's the answer, okay? Now the problem with the answer is that you will confuse it with the vagus. Sometimes this is large, sometimes it is small. You can divide this without any problem. You can't divide the vagus without any problem. So you're always trying to figure out, and again, looks pretty easy. I mean, you saw somebody who's not a surgeon, they go, how on earth? You got all this stuff laid out. Well, the problem is you're going to be looking at that, and you're trying to figure out, in that little space what all these different nerves are. It's one thing if you can follow it all the way up to the hypoglossal nerve, you can figure it out, but you usually don't have that level of exposure. So that can go. This one can't go. Hypoglossal nerve, it's in the bag. Now what? How are we going to know? Pardon? Stick out the tongue, injure it on the right side, points to the right side because the muscle of the tongue is being projected. If this side is paralyzed, the opposite side pushes it forward and it deviates, points to the side of the lesion. And so that's how you're going to tell. Again, probably not that big a deal, but sometimes they bite their tongue, and it can get all ulcerated and kind of nasty. So it's not something that you want. We're always looking for it. So you will get in your mind anatomically, so you're going to go skin, subcutaneous tissue, platysma, anterior border of the jugular vein, divide the common facial vein, get on the common carotid artery. Lift the common carotid up, dissect around it, look for the vagus. Once you got the vagus, you're going to dissect the vagus basically away from it. As you come up the anterior border, so typically we'll come up here, you may find sometimes if there are branches coming off, the carotid is going to come off right here. Typically they're going to come off the superior thyroid. Typically it's going to come off basically the external carotid. But you come up in this space, you will find those branches. So usually you get control of the external first. What's in the gap? We usually say you don't want to operate in the bifurcation. Stay away from the bifurcation, right in the crotch of the bifurcation. Because? Pardon? Carotid body's in there. So we pick it up. Now the anesthesiologist goes, holy shit, your blood pressure just dropped. Basically, you're down to a rate of 40 to 50. You can put lidocaine on it. It's because that's not the vagus. It's the bifurcation here that you get these hemodynamic changes are going to take place. So that usually doesn't happen, and you just basically block it. But nevertheless, this is very vascular. Just stay out of it. You don't need to get control right here. You need to get control a little bit further up. So typically put a ligature that we can take off around the superior thyroid, tape around here. Then you come down and so you've got a tape around here, tape around here. Now you're going to basically do the internal carotid last. Okay. And so typically you're going to dissect up the internal carotid artery. You usually know that the lesion is at the origin, and we're going to the point where it becomes blue. That'll tell you that you're getting up above the level of the plaque. Some people will pinch it just to make sure there's no plaque in there. Not totally sure about that idea. But as you start coming up the internal carotid artery, you are looking for the hypoglossal nerve at that point in time. And that's what I mean by thinking anatomically. This is just, after a period of time, you're just automatically thinking about these things as you go through it. Omohyoid. Every now and again, this is going to be low and you'll come across this. Can I divide the omohyoid? Yeah, Lord knows why that's there. You just divide it, okay? Sometimes you come across a muscle that looks like that way up here. It's not even shown in there. What muscle is that? Digastric. Okay, so the digastric is the other one you're going to see, fairly high up. Okay, doke. So they've taken out the sternocleidomastoid. Anything else to see here? Okay, again, superficial temporal artery, right here. Okay, that's what you want. That artery is occasionally used for doing ECIC bypass. If the patient's internals are occluded bilaterally, something wrong with the vertebrals, for example, then what you can do is you can bore a hole in the skull right here. Go straight down on the middle cerebral artery, take that artery down and sew it onto the middle cerebral artery. It used to be done much more widely than it is at the moment, but there's still an indication for it, and you should at least be aware that those options are there. Okay, nosebleeds. You're out there in the boonies. You're the only person with catheter skills. Patient's got nosebleeds. They come to you and say, you got to do something. What feeds the nasopharynx? Maxillary artery, okay? Typically this is the one you're going to have to go up there, find it, and embolize it. Most of the time the bleeding's coming off the maxillary artery. Sometimes you got to do it bilaterally. It's not something we're involved in, very often, obviously. Okay. Now what is this? Internal carotid artery. Okay, so we're kind of going through all of this and its relations. We did this huge carotid body tumor early last week. I mean, the thing is massive, and you're going to be coming up to the base of the skull and dealing with these things. So this is where you start getting into dealing with some of the other nerves. So you got to sling the hypoglossal, you got to move it. Do you know where the blood supply to the carotid body tumor comes from? Ascending pharyngeal, typically. Now, often it's multiple. In this particular case, it was almost exclusively off the ascending pharyngeal when we embolized it before we went ahead and operated them. But this is a situation where you can be up here in the styloid process. Digastric really comes off that, and the spinal accessory nerve, and the glossopharyngeal nerve is the one that if you injure the glossopharyngeal nerve, that's the one that really affects the patient's swallowing, and that can be a real problem. This is pretty advanced stuff. All right. Okay. The nerve that I personally have had most trouble with doing carotid endarterectomy is the marginal mandibular nerve. And basically, it's a branch of the trigeminal nerve. It crosses It's just a little superficial nerve right at the angle of the mandible. And I think what happens is we put the retractors in and we spread the retractors, it probably compresses the marginal mandibular nerve against the angle of the mandible. So we use these Gilpey retractors rather than the Wheatlanders in order to be able to do that, because it usually comes back. The ladies don't like it when it looks like that. So you get them to smile post-operatively. And this is Dr. Peden, he's the chief of the service. And it kind of, sometimes the marginal mandibular nerve, they smile and it droops a little bit and kind of hangs down. So usually it gets better, doesn't always get better. And then the other thing you occasionally get is so-called non-recurrent recurrent laryngeal nerve. Sometimes, typically the recurrent laryngeal loops off the vagus, comes up from inferiorly. Sometimes there's a direct branch. I have no idea how you would identify that intraoperatively, but it's one of the causes basically of recurrent laryngeal nerve palsy. Hypoglossal nerve, I think we've talked about it, way high up in the dissection. Every now and again this is going to be down here. Most of the time it's higher up. And you can see here, in order to get to the high carotid artery, sometimes you've got to start ligating these branches of the external carotid artery. You want to jump in?
You should go, because I'm going to do an injection.
Okay, yeah, no problem. So, a friend of ours, Dr. Silva, always said, remember the intracranial circulation, because he was at Texas Tech, he said, God made the intracranial circulation for Texas Tech. T and T, just remember that. T is for Texas. And so what happens is that the carotid artery comes up, enters the base of the skull, goes through the carotid canal, and enters the cavernous sinus. You remember all that stuff? And the first branch coming off, as it loops anterior, the first branch comes off is the ophthalmic artery. And so we have access to that for ultrasound, transcranial Doppler. If you have an occluded internal carotid artery, for example, you may get reversed flow coming from the supraorbital vessels, going back in through the eye and flowing retrograde. And so, okay, look over here. Don't look there. Who's next? You're up. What branch is that? Well, first of all, what's this thing? Okay, carotid siphon. Is this a carotid aneurysm? What would you do? How would you know? Okay, so you're going to go cross-table lateral, and you're just going to see that what you're looking at here is coming like that, and then it pierces the dura. Okay, good. One view is no view. You will be confused multiple times, unless you basically move that image intensifier and get it. Okay, so now we come up to here. What is this?
So that's the bifurcation anterior, or it's the branch of the anterior cerebral.
What one's that? Okay, that is the middle cerebral. It is flowing laterally, okay? You actually divide these up in M1, M2, M3 segments. You really don't need to know that. Okay, this is the one where emboli most frequently end up in patients with acute stroke or in patients who we're in arena on, and we send stuff south. And then it comes up basically and supplies the cortex. And these are all the branches of the cortex. What is that? T's for Texas. One goes to the middle cerebral artery. The other one goes to anterior cerebral artery. Now, what is this? Anterior. Why is there two of them side by side? Okay, ACOM is communicating through here. Those are the two anterior cerebral arteries going across the top of the corpus callosum, going posteriorly. And so that is what you're looking at. Okay, corpus callosum is here. Anterior cerebral was going back like that. You see them side by side. You know the anterior communicating artery is open. Okay? Those communications are incredibly important in trying to figure out, how you're going to manage these patients. So again, what we've got the cavernous sinus down here. This is do you know what that is? Posterior communicating artery going posteriorly. And again, you can't depend upon the circle of Willis. They may be present, they may be absent, they may be superb. The majority of patients, let's say we're operating a patient, patient's awake. We try to put a shunt in, we can't get the shunt in. Can we clamp the carotid? Will patients tolerate their ipsilateral internal carotid artery being clamped? In the overwhelming majority of cases, yes. Sometimes, no. And when you're doing carotids under local anesthetic, I'd say 90% plus is not a big deal. You can just clamp and go. But every now and again, they will immediately become ischemic. They start seizing. And so it's pretty interesting because if you're doing them under local and you get them to count, they'll go 1, 2, 3, 4, 5. And then you put the shunt in, you're shaking the same rate as the damn patient is seizing. That's how you got to get the shunt in. And they go, and you put it in and they'll go 6, 7, 8, 9, 10. They don't even know that this has actually happened. You got to sit down and get your breath, because if you can't get the shunt in, you got a problem at that point in time. And so these are the different areas of the brain that are going to be supplied. Now back to the vertebral that we've talked about. Okay, who's up? You're up. You're the red cell coming up through here. Talk me through the different parts of the vertebral artery. Straight up to the brain. Yeah. Okay. All righty. Not quite, but that's okay. So here we are. Where's it going? There's different parts of the vertebral. It's divided into V1, V2, V3 segments. So there's an extra osseous course. Okay? Right down here. It's not in the bony canal. Then it enters these transverse processes through these foramina. Do you care? You ever heard of Bow-Hunter syndrome? Turn my head, unconscious. You go to see Dr. Peden, he's going to go, huh, you're an archer, you went out, you fell on the ground, you got to have Bow-Hunter syndrome. That's what originally described from us. You can get bony impingement on these things. And so when they rotate their neck, it actually impedes the flow. So typically one will be diseased and the other one gets impinged upon, and then you have no flow to your hindbrain, you hit the deck. And so, yeah, it's important because these things can all be affected by bony prominences as it goes through those various different channels. All right? What happens up here? So this is C6, by the way. Usually, typically, C6 is where it typically enters the bony part of this. Okay? And what happens at C2? Enters through the base of the skull on the front of the medulla, and it meets up with a branch coming in from the other side. Okay? And one of the things that you'll see is that when you inject a vertebral artery and you're looking at the basilar artery, you will see a pacification. You'll see this on almost every vascular bed. And it will look like there's a big chunk taken out of the artery on the other side. And that's because there's non-opacified blood coming up from the other side. And it's just a flow phenomena that you actually see. You see this, for example, in the inferior vena cava. When we're putting in inferior vena cava filters, what happens is blood comes in from the left renal vein and it washes it out, and you see this basically segment that is really up there. And so you will get non-opacification. This is Dr. Bashara. He's the program director. Yeah. So these are just different things that can confuse you anatomically, but actually exist. So typically this thing is 3 to 5 millimeters in diameter. One vertebral artery can be tiny. Left is dominant in 50, right in 15%. These are the different segments that we've really already talked about. And you can imagine how this can rotate and get them impinged on. Vertebral from the other side, what's that? We already mentioned that artery already this morning. PICA. So in PICA syndrome, that segment doesn't exist. It dead ends straight into that. You cover that vert, you infarct your cerebellum. That's not a good situation. I'm not entirely sure how I'm not sure we would pick this up, in advance, but we had a patient of mine this patient with a carotid body tumor that we usually study these things with the interventional neuroradiologist. He shot it and went PICA. I've gone back several times and I still can't figure out exactly how he called it PICA, but the patient had PICA syndrome. This is kind of what it looks like. These are the different segments that we've talked about before it goes into the bony foramina. Then here's basically as it's coming through the transverse processes. Here's it loops anteriorly, and then V4 basically before it joins up into the basilar artery. Now, posterior circulation symptoms, typically you gotta disaffect both vertebrals before this becomes symptomatic. This thing is the basilar artery is so critical, you got redundancy that's built into it pretty well. I go to a conference that talks about complications, and then when you rupture a basilar artery, you're dead. You occlude a basilar artery, by and large, you're dead if you do it acutely. And so people do not tolerate things going wrong with their basilar artery very well, and they tend to have a constellation of different kind of symptoms that can actually be associated with this. Okay, so this is just different examples of what the vertebral arteries look like. Okay, tell me what's going on here. Who's next? You're up. A little confusing.
Yeah, I mean, could be a narrowing. You might need to change your view.
Okay, so again, this looks narrowed. Doesn't look that badly narrowed, but that's probably not the origin. Again, these can be very difficult to get the right angle. The aorta is easy, just swing it cross-table lateral. But trying to nail the origin of the vertebral artery with the right angle can be difficult. If you've got a CAT scan, you can look at that and determine that angle in advance. But what you're probably not seeing the true origin of it here coming off the subclavian, and you have to work to be able to show that. Where's the bifurcation of the subclavian artery or the innominate artery? Is it here? Is it here? First one or second one? Pardon? Yeah, well, it sure ain't there. Okay, I mean, that's the one thing you can tell. That's not the aorta. You can see that double density here. The bifurcation is at least here. For all you know, it could be way down here. You just can't tell because you haven't optimized that angle properly. So that's the vertebral artery snaking up here. What about this vertebral? Coming off the aortic arch. Another example of it coming off the aortic arch. You see that artery here? That's the lima. Difficult to see because it's all superimposed. And this is the world that you're going to be living in because you're going to be trying to figure it out. And every now and again, even though that vertebral typically comes off proximal, sometimes they can come off in very bizarre different situations as you're seeing up here. All right. Kind of already talked about most of this. Going through this. This is just the area of the brain, the posterior cerebellar artery, typically coming off the posterior circulation, but usually there are posterior communicating arteries that are going to show you this. And this is the whole circle of Willis. Anterior cerebral, anterior communicating, anterior cerebral continues anterior, that's the A2 component of it, posterior communicating arteries coming back to the basilar arteries. All right, back up in the head. Okay, who's up next? All right. What's happening here?
It looks like it's the internal carotid that's,
Carotid,
yeah, and it's branching off into the MCA.
MCA, up in basically the parietal lobe. What's this?
And the ACA
ACA.
in the middle, and then ACOM.
ACOM's here. 2 ACAs.
And it seems to be going over to the other MCA.
Yeah, so what's that? Think backwards now.
So ACOM again?
Well, ACOM's here.
PICA. Wait.
Now, anterior cerebral.
Anterior cerebral.
Left anterior cerebral.
And the MCA.
Left MCA. What's missing is the carotid artery. And so this is a situation, you can't tell absolutely from this, but it's likely that the internal carotid artery is occluded. Now this is important to us because you may be getting consulted in this patient because the patient has got a high-grade right carotid stenosis. Occluded left side, carotid stenosis on the right side. Does this appeal to you, Dr. Peden, to actually go ahead and intervene on these patients, or does your anxiety level go up a little bit in dealing with this? More than a little, yeah. I mean, so you worry about this. This is a situation it's not going to stop you operating on the patient. Now, we typically use a lot of transcranial Doppler, and you get to meet the guru of transcranial Doppler tomorrow, and it's incredibly valuable. Transcranial Doppler fires a beam that comes right in through here, and it will tell us about. This is typically 5 to 7 centimeters depth from the skull. We can see the middle cerebral artery. We can see the ACA. Sometimes we can see the ACA on the other side. And so it's very reassuring if we clamp the carotid artery. It ain't going to happen in this case, I can guarantee you. But typically what will happen is we can see the MCA velocities. And if the MCA velocities stay above 50-60% baseline, we don't even need to shunt the patient. The patient should be okay. I guarantee you in this situation with the contralateral carotid out, this is probably going to go drop much more significant than this. And then we end up put a shunt into that.